Section 1. Venous Anatomy and Physiology.
Picture the venous system as a strict one-way street. Blood's got to flow from the superficial compartment right into the deep compartment. And how does it fight gravity to do that? Two ways. First, the calf muscle pump, literally your gastrocnemius and soleus muscles squeezing during a walk. Second, a precise set of one-way valves. When those valves get lazy and don't close, you get backward flow or reflex. The blood pools and those superficial veins dilate. Just remember the golden rule here. Flow is always superficial to deep via those perforating veins.
Section 2. Chronic venous insufficiency.
So over 80% of chronic venous insufficiency cases, they're driven by that exact valve incompetence we just talked about. To track how bad it's getting, you absolutely need to know the CEAP classification. It maps the whole journey. We start at C0 with no visible signs, move to C1 with those asymptomatic spider veins, and progress up to C3, which brings noticeable edema. But once you hit C4, the skin actually starts to change. You get pigmentation at C4A and that thick, woody lipodermatosclerosis at C4B. Finally, the tissue just gives up. C5 is a healed ulcer, and C6 is an active, painful venous ulcer.
Now, a classic exam scenario: arterial versus venous ulcers. You have to be able to tell them apart instantly. Arterial ulcers? They're super painful, have punched out discrete edges with a pale base, and usually show up right on the tips of pulseless toes. But venous ulcers are totally different. You'll usually spot them proximal to the medial malleolus, and they're surrounded by classic stasis signs. Think pitting edema, hyperpigmentation from hemosiderin, and that lipodermatosclerosis we just mentioned. So how do we fix it? Medically, it all comes down to gradient compression stockings, specifically targeting that 30 to 40 millimeters of mercury gradient. Patient compliance is literally the biggest roadblock here. If they already have an active ulcer, we use Una boots, which combine firm compression with zinc oxide paste to heal things up. Surgically, we've come a long way. Nobody wants painful vein stripping anymore. Today, endovenous ablation using a laser or radio frequency gets you the exact same results with a fraction of the downtime.
Moving on to Section 3. VTE, Risk and Diagnosis.
Okay, you have to explicitly know the difference between these two severe manifestations of DVT. Phlegesia caerulea dolens hits the deep channels, but crucially, it spares the collateral veins. You still get severe swelling and cyanosis, but some blood is moving. On the flip side, Phlegesia alba dolens is when that massive clot extends right into the collateral system. This causes profound blanching, which is actually a clinical sign of arterial ischemia. A quick trick: caerulea means blue, alba means white. Keep them straight to save the limb.
When it's time to image, duplex ultrasound is your undisputed gold standard for suspected DVT. It's over 90% sensitive for proximal veins like the femoral and popliteal. If you're hunting for a pulmonary embolism, contrast-enhanced spiral chest CT has totally dethroned the old V/Q scan. It's fast and it's definitive. We literally only use a V/Q scan now if a CT is completely off the table, like if the patient has severe renal impairment.
Section 4. VTE, Prevention and Management.
Let's talk prevention. We rely heavily on low-dose, unfractionated heparin, graduated compression stockings, and intermittent pneumatic compression devices. And here's a cool fact: those pneumatic devices aren't just physically squeezing the leg, they actually upregulate blood fibrinolysin activity to actively break down clots. But for active outpatient treatment, the chest guidelines are crystal clear. Low molecular weight heparin, like enoxaparin, is strongly recommended over unfractionated heparin. Why? Superior safety, a longer half-life, a highly predictable dose-response curve, and a much lower risk of heparin-induced thrombocytopenia.
Here's a massive high-yield board testing point regarding IVC filters. Prophylactic filters are almost never the answer. The strict, evidence-based rule is that filters are only for patients with a proven DVT who either have an absolute contraindication to anticoagulation, have suffered a major complication from it, or just keep getting recurrent VTEs even while fully anticoagulated.
Finally, Section 5. Lymphedema, Diagnosis and Treatment.
Primary lymphedema happens due to congenital aplasia or hypoplasia of the lymph vessels. Your absolute best clinical clue here is simply the patient's age. If it shows up in the newborn, that's congenital lymphedema, like Milroy disease. If it hits in the second or third decade of life, it's lymphedema praecox, also known as Meigs disease, which mostly affects females. And if the swelling starts later, say after 30 or 40, we just call it lymphedema tarda.
Now, secondary lymphedema is way more common overall. It happens when normal lymphatic drainage gets damaged or blocked. In the US, board questions love to test you on surgical node dissection or radiation as the cause, but zoom out for a second. Worldwide, the single most common cause is actually a parasite called Wuchereria bancrofti, which causes filariasis. Keep that global perspective in mind.
When you absolutely need to nail down the diagnosis, lymphoscintigraphy is your go-to imaging study. You inject a radiolabeled colloid into the web space of the toes or fingers. It has a 92% sensitivity and a literal 100% specificity for confirming lymphedema. It completely blows the older, more invasive methods out of the water.
Let's test your retention really quick. Imagine a 72-year-old man walks in with a confirmed proximal DVT. Did you know up to 60% of these deep vein thrombosis episodes are totally asymptomatic before they strike? And many don't even have obvious hypercoagulable triggers. As vascular medicine keeps evolving, you really have to wonder, how many silent clots are we missing every single day? And will targeted genetic screening eventually replace these reactive algorithms altogether? Think about it, trust your clinical exams, and keep asking those big questions. Thanks for tuning in to This Explainer.